Now, endocrine, thank goodness we don't have a lot of medications in endocrine, but we are going to take a journey and look at this. And what we're going to do is we're going to talk about diabetes 1 and 2, and we're going to think about, we're going to do thyroid up and down, and just a brief note on constitutional growth delay. But with our endocrine disorders, we want to think about diabetes is a disordered metabolism, and we know we have type 1 or 2. No longer is age a criterion, but we do know type 1 produces ketones. We also know that it used to be called juvenile diabetes, and we do know that type 1 has markers. Gosh, you could do a lab test and get these markers, HLA, DR3, and 4, strongly associated with type 1. We don't have markers for type 2, okay? So we think about your pancreatic islet cells are destroyed. That's the autoimmune aspect of it. Often it can be an infectious or toxic environmental insult that occurs. We think about the 3 Ps and nighttime enuresis, weight loss, increased hunger, fatigue, weakness, paresthesias. I have tingling in my legs, tingling in my hands. Level of consciousness changes. Now for the pediatric questions, they're not going to go into DKA and HINK and all that. But I just want to tell you that you can have somebody that gets irritable, right? Gets confused. Sub-Q fat, muscle wasting, dysfunction of the peripheral sensory nerves, and in advanced disease, you're going to start seeing things on the eyes. Cotton wool spots. Maybe even peripheral vascular insufficiency, so they can't feel the bottom of their legs. This is advanced. You know what I'm saying? This is not going to be early on. May show some signs of a dehydration. You're going to look at your labs. You know, your labs are important. When you think about getting a 126 on 2 separate occasions with your blood glucose fasting, random blood sugar more than 200 with your 3 Ps. Now, you know what? You guys could go eat a hamburger at lunch, but you don't have the extra symptoms. Your blood sugar may go way up. Doesn't mean you have diabetes, but you got to have the symptoms that go along with the rise. Also, urine and blood that have ketones in it, glucose in glucosuria and ketonuria, plasma ketones, as I mentioned with type 1. We want to think about, here's your A1C. Now, it says 5.5 to 7. That's kind of normal, not somebody with diabetes. But what if you had, you know, that's a 3-month average of blood glucose. What if you had a 4.8? Too tightly controlled. Maybe you had a 9.2, not controlled enough. So it's a barometer, right, for your glucose over a 3-month period. Impaired glucose tolerance, fasting blood glucose between 100 and 125 is considered, used to be called borderline. They now call it pre-diabetes. We know it's important to establish all this good baseline information, family history, get your labs, cardiac risk factors, do a good PE. Your PE should include a good neuro examination, foot examination, and so forth. Dietary teaching, carb counting. Oh my goodness, how important is that? We know it's really important to get a nice balance. People think that when they get diabetes, they need no carbs. No, they need a little fuel for the tank, right, to keep the car going. So it's important that they know there's a nice, well balance to this. The rule of thumb, anybody that has ketones needs insulin. So insulin is going to be given 0.5 units, kilogram per day, giving 2/3 in the morning and 1/3 in the evening. And this is just one iteration of how it can be split, okay? You can continue to even split the evening dose. And yes, we still think about we think about our short-acting MPH and our regular. Do you all remember Somogyi effect and the dawn phenomena? Both of those, if I could just share with you, both of those cause what? They cause early morning hyperglycemia. That's probably what you want to highlight. But it gets there because of 2 different managements, 2 different ways, and you treat it 2 different ways. The Somogyi effect is when nocturnal hypoglycemia stimulates a surge of counter-regulatory hormones that raise blood sugar. So that if you ask that patient, that if they say to you in the morning, my blood sugars are a lot higher in the morning, you need to ask them to get up a couple times about 3 o'clock in the morning and check their blood sugar. That will tell you, because if at, say, like 3 in the morning, they're hypoglycemic, then you know that this surge of counter-regulatory hormones is the culprit. Therefore, in the morning, they rebound. So what you want to do for a patient with this, you want to reduce or eliminate bedtime insulin. So you want to make sure you take it earlier in the day. We want to think about, when I think about teenagers, the one that's probably more prevalent is dawn phenomena. This is an easy one to think about because this is where the tissue becomes desensitized. What desensitizes it? Guess what's released during the early wee hours of the morning? Growth hormone. Think about teenagers, growth hormone. And so therefore, if it's released, what happens is the blood sugar gets progressively higher. Think of this, the dawn phenomena. The dawn rises, the sun rises in the dawn, right? So you want to think about that's what it causes it. So this is a child that would need to have an addition or an increase of bedtime insulin so that you get them through the night. Does that make sense? To offset that which occurred. Now type 2, we have no markers, no islet cell antibodies. It's mainly we rely on family history, obesity, and other types of lifestyle issues. There is no ketones in this. We also know that it's an insidious onset of hyperglycemia. You could probably get some skin disorders, pruritus, vaginitis, neuropathies, chronic skin infection. There's acanthosis nigricans, which is that kind of that thickening of the skin around the nape of the neck, under the breasts, and areas of moisture. The 3 Ps. And there's just thinking about what that might consider there, acanthosis nigricans, a thickening of the skin. Because what happens? The sugar has somewhere to go. It has to build. It stores into these areas of moist skin areas. We also think about pretty much your lab and diagnostics are the same as type 1, baseline evaluation screening. You want to think about family history, and certain ethnic groups tend to have a little higher prevalence. We also want to think about, when do we start screening kids? Right there, around 10 or at the onset of puberty, especially if there's family history, there's obesity, there's inactivity, and so forth. And pretty much we think about management. Now, what is it? Can you tell me what is the only oral anti-diabetic that's FDA approved for children? Metformin, the only one. We don't have DPP-4s, GLP-1s. We don't have all those other ones. So that's the only one you need to know about, and we know that that's an important one, and kids do very well on it, and they lose weight very nicely. Now, sometimes we have to give kids that have, if you have a child that has pretty high sugar, say 350 or higher, you might need to give them a little insulin until their sugars come down while they're on metformin. So there you are. I don't need to read you the oral antidiabetics. You were pretty familiar with it, and so there you go. Thyroid disorders, up and down. I cannot tell you how important. Pink Pig, everybody gets a question on something about the feedback loop. Now, can I tell you right now, with hyperthyroidism, can you tell me what is the most important lab, T4 or T3? Okay, everybody picks T4, but it's T3. That's okay, that's okay. I just want you to know, that's one of the ones that's on the test, so we're going to talk about that. But when you think about the feedback loop, we've got the hypothalamus sends the releasing hormone down to the anterior pituitary. The anterior pituitary looks at the stimulating hormone that goes down to the thyroid. If you're low in your thyroid, your T4 is going to be low, and guess what? Your TSH is going to go up because it's going to say, we need more help. I'm going to talk a little bit more about T3 in a moment, but let's do the hyperthyroid. I'll just start off by saying hyperthyroidism, you will not be managing them. They will have a pediatric endocrinologist for this. They will be on certain medications that they need to be treated, but let's look at, this is the one where you have Graves' disease, enlarged thyroid, hyperactivity, too much thyroid, antibodies that may affect the thyroid gland itself. Females, adolescents are real commonly seen. Often also other autoimmune disorders may be associated. If I could just tell you all of your symptoms, everything's kicked up a notch. I think of Emeril Lagasse, the famous New Orleans chef. He says, bam, kick it up a notch. Everything's kicked up. Okay? They're more tachycardic. They lose weight. They fine hair, menstrual irregularities, sweating, palpitations, atrial fib, which is paroxysmal, not to where you need Coumadin, of course, tachycardia, hyperactive DTRs. So the most important test for thyroid that's too high, hyperthyroidism, is the TSH. Typically, what you're going to see is your T3 would then be the next one that will be evident, because you're going to want to see whether or not they have to have a medication called Cytomel. But that's the endocrinologist is going to determine that. We also know it's important to check things like your ANA to see if there's other autoimmune disorders. The medicines they're going to go on, they need something to treat those symptoms that are so kicked up. Good old propranolol is a good choice. They also will probably be on thyroid drugs such as PTU, Tapazole, and they may have other treatments like surgery, iodine, Lugol solution, but again, most of that's going to be managed by the endocrinologist. So we think about the hypothyroid child. Hypothyroidism, diseased thyroid gland deficiency of the pituitary, and this is where you get autoimmune thyroiditis. You've heard of Hashimoto's? Did you love that word? Hashimoto's thyroiditis. And these are individuals that, like in the newborn, we have a newborn screening test for this, right? So we're checking for the newborn. We know that they may have an underdeveloped thyroid. 1 in 4,000 live births is the commonality. For the juvenile, which is autoimmune, like your Hashimoto's, pituitary deficiency or hypothalamic deficiency or iodine deficiency, damage to the gland. The neonates and the infants that we see typically will show things like growth deceleration, poor feeding, bradycardia, they'll be hypotonic. Everything's kind of like what? Sluggish. Weakness, arthralgias, cold, constipated, they gain weight, sluggish, skin involvement, thick, puffy tongue, all their tendon reflexes are going to be diminished. So when we think about, we do have the newborn screening test, the TSH is elevated, and they have a decrease in their what? What's going to happen? Their T4, what's going to happen with their T4? It's going to be low. So TSH is going to be high. It's completely opposite. T3 is not a good indicator here. T3 really has no role. So basically, doing other things like looking at their anemia status and liver enzymes and so forth. These kids are also going to be referred to pediatric endocrinology. And what's the drug of choice? Good old Synthroid. This is one of the medication drug groups that has a big variation in terms of generics, up to about 20%. So it's important. And did you know the half-life of a Synthroid tablet is 45 days? And you must take it completely unattached to any food or other medications. Now, short stature, the one thing I want to say about short stature is they're probably not going to ask you about the standard deviation, but, kids that don't grow more than 4 centimeters a year, we already said school agers gain, 2.5 inches typically, in the year time frame. But we know that there's a family genetic variant that means normal linear growth velocity and short target height. That means the child reflects their family patterns. And then the constitutional delay, bone age is consistent with height age. Well, that's important because what happens is if you did what? If you did bone tarsal or carpal x-rays, they would show that the child's bone age is exactly where his height age is. There's no discrepancy. When you have no discrepancy, that is a kid that should not take growth hormone. What's going to happen if you take growth hormone inappropriately is the child's growth plates will close prematurely, and you're speeding it up, closing it sooner, and so you're going to actually thwart their growth. But the constitutional delay child is where they have a slow growth rate for the first 2 to 3 years. I'm sorry, I'm going to stand in front of you. Then a normal growth velocity. And again, by the time they finish their growth patterns, they're going to reflect their family. Does anybody know what the growth hormone, one of the major side effects is? Aside from closing up their epiphyseal plates if it's given inappropriately, it's headache. They get a major headache to the point that it's almost so uncomfortable they can't even take the medication. We want to think about signs and symptoms of chronic disease, neglect, endocrine deficiencies. All those would be important. You know, kids that have concerns about growth are probably going to be what? Wanting to see an endocrinologist. And the endocrinologist will do all the different testing that's involved, a pretty good workup. As you can see here, sweat test, stool for O&P, growth hormone, also checking for celiac disease. They're going to make sure everything has been covered. And if it comes out to, in addition to that, the bone age is exactly where they need to be, they don't need growth hormone. So basically, you know, that good referral to the endocrinologist will help support them in that decision.